Good morning and welcome to the 98th edition of COVID-19 Talk with Local Health Authorities. Joining me is Dr. Erica Brown, representing Harris County, Dr. David Pearce, representing the City of Houston. Special thanks to Kathy Finninger, past president, Rotary Club of Houston, for providing us with these questions over the 98 sessions that we've had so far, and to our producers, David Castillo and Priscilla Key. I'm Stephen Williams, director of the Houston Health Department. Okay, y'all, three more to go. Transmission and current status. Looks like Harris County is at yellow medium status. What should we know?
So yellow status means that unfortunately hospitalizations are rising, positive tests are rising. So of course we would like for everybody to stay up to date with their COVID vaccines, including getting the booster. Get tested if you have symptoms or have been exposed. The federal government has restarted the free COVID testing kits, so you can go online and request those kits, and they do come fairly fast. Wear a mask if you have symptoms. Certainly, if you have a positive test, to isolate for a minimum of 5 days or until you are mainly asymptomatic. Consider wearing a mask in general, especially if you are going into crowded places or around others in smaller workspaces. For Harris County, we do require 75% occupancy when we go to yellow.
China no longer reports cases, but the news showed 37 million may have been affected there on a single day in December. That number is incomprehensible. What does it predict for the rest of the world? I saw that on the news this morning about them not reporting cases.
Yeah. So we actually, Dr. Pearce and I had conversation about this a little while ago this morning. We're not really clear on the specific numbers and how China is calculating their numbers. We do know that unfortunately they are seeing a huge surge, but not clear again on the numbers. The quarantine restrictions were lifted under the zero COVID policy. These reasons may have contributed to the calculation of this number. And so meaning that they just weren't aware prior to. There's no source of data that's being released by China health officials. However, if the trend is accurate, nationally, we'll peak in early January.
That's now.
Now,
Based on wastewater, can you estimate how many people have it, or is it just a level found which could be made of one person with a lot of virus or many with it?
This is a good question. That one person would have to have an awful lot of virus to account for it. But so the answer to the question is that no, you really can't estimate the number of people based on the amount of virus that we're finding in the wastewater. There's a number of reasons for it. We're collecting this from these wastewater treatment plants, which cover, they're all varying sizes. One of them is nearly 50% of the city, and then the rest is a variety of smaller ones. But still, there are hundreds of homes and/or buildings. Thousands of toilets, if you will, per wastewater shed that we take this from. And the other thing is that throughout an illness, when one person is ill, the amount of virus they produce in their stool varies throughout the illness. And so it kind of parallels how sick they are. So when they're at their most symptomatic, they're producing the most amount of virus in the stool. But then even after they start feeling well, it will continue to produce virus. And that's often just viral debris that the body is just getting rid of. These aren't active viruses. But in the wastewater, that's what we're looking for. We're looking for fragments. So you really can't estimate the number of people that are infected based on the amount of virus we're finding in the wastewater. So that's why we follow the trend. And again, the absolute value that we report isn't what's important. It's which direction is it changing and how steep of a change are we seeing over several weeks.
Wastewater testing in planes is interesting. Is that common?
So it's not common. It's never been done before that I know of. In fact, I'm not even sure that it's being done now, but there is talk about it. Again, the problem here would be a couple-fold. One is that you would have to take the sample from all these different aircrafts and you'd have to test them. And again, we look for fragments of the virus in the wastewater. And so if we're doing this to see if there are infected people coming back, well, there's going to be some people that are, past the illness or no longer infectious, but they're still shedding virus. So that's going to be in the wastewater. If we're doing it to see if there are new variants that are popping up, the way the tests work is you need to know what sequence of amino acids you're looking for. So it's not a good way to determine or to discover new variants. You really need to get that from a patient and then sequence the entire virus from that patient, because in the wastewater, we're just looking for fragments. So it works differently. That would not be a great way to seek out and find new variants. And I think it would probably not be really helpful to see if there's a lot of folks that are coming in that are infected, because even folks who are now better are still going to shed some virus, and that's going to be detected in the testing.
Is it correct to say home tests are resulting in more false negatives than in the past?
No, I don't think that that's a correct statement. Home tests absolutely have value when testing for COVID. It is true, however, that if there is a low viral load, that they may not detect earlier in infection. And so it's advised to test again in a day or two, because the fact is as well, if the test is positive, it's positive. And so that's what home tests are used for, is if you're feeling symptomatic, to get a home test so that you're not going out into the community, potentially exposing others, as well as for convenience, to be able to isolate and know what you're dealing with as well. So they absolutely have value. It's just a matter of knowing the limitations. If the test is negative, retest in a day or so to make sure that the test is negative, because the limitation of the test, which doesn't mean that it doesn't have a valuable use, but the limitation is that if the viral load is low, it may not be able to detect as early.
Travelers from China to the U.S. and other countries must test 48 hours prior to boarding their planes. PCR tests may not show a positive during that period. So does this do any good at all, or does it create overconfidence in safe flying?
So the PCR tests are really highly accurate, right? So, and they're also very sensitive. In fact, that's one of the problems that we had with them. If you recall, when it came to, you had to test negative to get back to work. Well, people continued to test positive long after they were feeling better again and were no longer infectious, because it's so sensitive. So the rapid tests are the ones that are more likely to give a false negative if you test someone too early, as Dr. Brown just explained. But the PCR tests are far more sensitive. Now, are they absolutely 100% protective? No, because there is still going to be some people who are still so early in the illness that even the PCR test won't pick it up. And then there's also people who will test 2 days before and are negative, and then in that 48-hour period, they become exposed, and then when they land in the country they're traveling to, they then develop symptoms there. So there's no perfect way.
Are all the new variants from Omicron now?
It's talking about this as well. All is a very strong word. I would say almost everything that we're seeing, yes, is a variant of Omicron. But just in general, if you look at the lineage across the board, right? We started with Alpha, then we went to Delta. So it's the family tree that just keeps branching off.
Family relations, eh? You have mentioned one hospital doing a good job testing all patients for COVID types. What is the latest analysis?
Yeah, so we look at a couple places, and there's more than one hospital that does it, but one hospital seems to do a larger percentage of their patients than some of the others. But we have got good relationships, so we're getting good data from the hospitals. And we're finding, goes back to the previous question, pretty much everything is within the Omicron family. No big surprises there. The big talk now is the XBB and XBB 1.5. We are seeing a little bit of that in the Houston area. It's just starting. That's making big news up in the Northeast. But for the most part, it's all Omicron, and no surprises at this point.
A Wall Street Journal article sounded an alarm on XBB, saying it had evolved to elude antibodies induced by the vaccine. Please explain.
So, as we've discussed in previous episodes, these mutations involve changes in the envelope. I think previously I've referred to the Oreo cookie, and so they involve changes to the different types of filling for the cookie. Okay, and so this XBB1 and XBB1.1.5 are changes to the filling in the cookie. And so what we currently have to vaccinate with is more specific to some of the earlier Omicron variants. I will say it does appear, and we're very, very early in this. Again, as we're continuing to monitor the pandemic as a whole, data is still being evaluated across the board. It appears, though, that the illness, the sequelae from it, is a little bit less than previous. So while it's very transmissible, it's not creating severe illness, which is a good thing, because it looks like the vaccines may not be as effective for these two variants.
Is the flu season almost over this year?
Oh, no. No.
My personal experience is absolutely not. I get the flu in
Get
February.
your flu shot. Get your flu shot.
Yeah.
They're free. Get your flu shot.
Absolutely not. Can you get COVID and flu at the same time?
Yes. Yes. Nothing. Moving on. Yes.
If you aren't sure what you have, would it help to start Tamiflu while awaiting results?
Yeah, I'll take this. So, you should be able to get results pretty quickly. There are certainly the COVID tests that we've been talking about, the rapid tests are rapid tests, right? And you can get the answer within 15 minutes. And there are rapid flu tests as well. Now, interestingly, the rapid flu tests are, ironically, they've been around a long time, they're not as accurate as the rapid COVID tests. So, and here's the other thing, you could test negative in both of those. And keep in mind, there are plenty of what we call para-influenza viruses that are circulating, which are not the flu, but make you feel similar to the flu, generally not as sick. So you really should be able to test for one or both. And based on those results, your clinician should be able to, then have a conversation as to which way to go by, for that. So just starting one while you're waiting for results, no, go get tested and then make a decision after that.
Is there any connection that flu and RSV seem to be dominant where COVID is down, low where COVID is high?
I'm not sure whether we're talking about geographic location or we're talking about the science of these viruses. Geographically, I'm not aware. But with regard to the science of the viruses, there is some data that shows that rhinovirus can interfere with the SARS-CoV-2 virus, and that there's also some evidence that flu and COVID can block each other. But as we just said, it is very possible and does happen where you can have both COVID and flu infection. You can have both this and that, A, B, C, or D, pick one. You can be co-infected, and the data is still out on how these two may block each other, but even in blocking, it's not 100%. You can be co-infected with many things.
In retrospect, and perhaps for the next year, what would have been the best date to get a flu shot to hold us through what was an early season this year?
Yeah, so this is a good question. So, the flu shot generally becomes available for most people. We recommend that you get your flu shot in September and October. The flu season generally runs from about October all the way through until May. So going back to the earlier question, no, flu season is not over. We did just have a big wave of flu very early in November. That does not mean, and we have seen it in the past, surely, that you can get two waves in the same calendar, the same season, the same flu season. So we recommend that most folks go ahead and get vaccinated in mid to late September or October. But certainly if you haven't got vaccinated yet, it's not too late. Flu season isn't over, but this big wave came through. If you didn't get it, if you didn't get the flu and you haven't got vaccinated, I'm anticipating another wave. I'm fully anticipating we get another wave come, late January, early February, because that's when we usually get it. So, yeah, that's when I would get it. And especially if you're elderly or if you've never been vaccinated before, you need to get the 2 shots. You want to get started on that early.
Current boosters last about 2 to 3 months. The CDC says they may reduce the risk of infection and hospitalizations by about 50%. I'm over 65 and my last shot was a bivalent at the beginning of September. What is next? How protected am I? What would be the downside to getting another shot now?
So there is no recommendation if you've had your bivalent booster to get another vaccine. The best thing that you can do is what we would consider other more universal precautions, which is again mask wearing, washing your hands. Certainly, if you're feeling ill, get tested and stay at home. But mask wearing and hand washing and good hygiene are probably the best things that you can do, and to be cautious as you determine where you go out to, whether it be out to dinner, whether it be out to an event, etc., based on your risk, because there is no additional recommendation for another booster. Having said that, though, there is some inherent immunity once you've been vaccinated and with the booster. And so while the highest efficacy lasts for several months, there is still going to be some efficacy because your body recognizes the SARS-CoV virus. And so there's still some protection there.
I have to admit, I've thought about that too. Please comment on the statement. COVID-19 vaccine temporarily alters heart rate variability, and it should be normalized in 3 days.
Yeah, so this was a study that was done out of South Korea, and it was by a bunch of researchers who look at heart rate variability, and so they decided to look at patients who had been vaccinated with the COVID-19 vaccine. And what they found was, now this gets a little, well, it gets quite technical, but what they found was that there are differences in the root mean square of the successive differences between normal heartbeats. Okay, well, we always deal with the root mean square of successive differences between normal heartbeats, don't we? I mean, everybody does that. When you go out to your doctor, it's probably the first thing you ask. Hey, doc, what's the root mean square of the successive differences in my normal heartbeats? So the point is that this is a group of folks who were looking at a specific variable. And what they found was that for about 3 days after being vaccinated, folks do get a little bit of a change in their heart rate. It is a very subtle change. It only lasts for about 3 days. It appears to have zero clinical impact, no clinical importance whatsoever, but it is there. What they also found was that, one of the things they looked at was if the people are symptomatic, and sometimes after you get your flu shot, and I think many of us experience this, you get achy and you get the sore arm, you might get a little feverish, you feel a little crummy for a day or two. Well, that's going to change your heart rate too. Your heart rate's going to generally go up a little bit. But they also found it in folks who had almost no symptoms. But again, the authors come back and they say this is just further evidence of the safety of the vaccine, and that they were looking to find something very specific. And what they found was specific but very subtle and had no clinical impact. So I fear people will take this and say, see, here's another problem. No, this is further evidence that there's basically no problem, or at least in this area there was no problem with the vaccine. This is one of those articles that can be completely misinterpreted if somebody wants to misinterpret it.
Yeah, I was thinking about that. There's no way that I would be telling people that their heart rate's going to slightly change if they took a COVID vaccine.
Yeah.
Almost too much information. An immunology study says that mild cases of COVID can result in a reactivation of viruses with similar symptoms to chronic fatigue syndrome. Does reactivation mean that you get the exact type of previous virus?
No, it doesn't. Similar to what happens with Epstein-Barr, Guillain-Barré syndrome, or even shingles, is something that most people are familiar with. There are some viruses that lay dormant in the body systems, and when the body is stressed, they can reactivate. And having COVID infection is considered a stress on the body. And so it reactivates other viruses that may have been laying dormant in your system and can cause chronic fatigue syndromes and other sequelae. So for instance, with shingles, can cause the rash and things like that. With Epstein-Barr and Guillain-Barré syndrome may cause some neurologic issues. But these are viruses that were asleep, and then they get woken up because the body is stressed in some way. And in this case, the stress would be COVID infection.
I've heard long COVID symptoms described as neurological, where the brain interprets and distorts sense data, like the ability to smell or taste. Is that an accurate interpretation?
Well, it is, in that the neurons that for smell are basically right at the base of the brain. It's right around the nose, obviously, and your taste buds are in your mouth. And so they actually, the science has shown that with the COVID infections, that those neurons, because they're directly exposed to the virus, get impacted. And this is why people have a loss of, their ability to taste and smell things. Not universally, obviously, only some people. And most people, they recover. It's very rare that somebody has permanent. In fact, I don't know of any case somebody has. Well, there's one case I heard of where somebody had a loss of their sense of taste for many, many months. Usually it comes back within a few months. I believe it's 6 months or less. So it can go on for a long time. But yeah, it is neurological.
I thought loss of smell and taste were symptoms of COVID Omicron. Any new symptoms?
So in fact, loss of taste and smell were predominantly symptoms of the previous variants. So the Delta variant, the Alpha variant. It doesn't mean that if you lose taste and smell, it can't be Omicron variant. And in fact, if you do, that's a pretty strong sign that you need to get tested. But most Omicron variants and most of the symptoms are more cold-like symptoms. They are not loss of taste and smell.
Any new information on risk for those unvaccinated while pregnant?
Well, the one thing I think that pregnant women need to keep in mind is that the COVID infection is dangerous. It can lead to, we've had moms who have died. We've had a very measurable amount of preterm births and stillbirths and miscarriages. This degree of illness that the mom is experiencing doesn't seem to necessarily relate to the OB complications. So you don't have to be really, really sick with COVID in order to have for the baby to have a problem. It could be a mildly symptomatic mom, and yet the baby will still have some serious problems. And the bottom line on this is that for all the concern about the vaccine, the incidence of problems with the vaccine are infinitesimally smaller than the rate of complications for a mom who contracts COVID. So no, nothing really new, but I think that's an important point that we need to stress, is that if you're pregnant or if you're planning on getting pregnant, then you need to seriously consider getting vaccinated.
Yes, David, if I could add to that just really quick. Harris County Public Health has a program that we're launching for maternal health, and looking at the statistics and the data over the last 2 years, exactly to your point, the data is so clear that unfortunately the maternal mortality rates, a significant part of the increase was moms who had COVID. And that's maternal mortality, meaning the mom passed away. And so I can't stress enough how important it is to get your vaccine.
Preventable deaths.
Long COVID has impacted many. Do we know anything new?
The research is still ongoing. Obviously we're still trying to figure out the why behind it. So there's nothing new. There's just a lot of research ongoing.
Okay, medicine. FDA gave field approval of tocilizumab. Please explain when and why this treatment is used.
Yeah, so this is a new monoclonal antibody that doesn't really work specifically on COVID, but it inhibits the interleukin-6 receptor, which is part of the inflammation response that you get to the COVID infection. And so it's given IV intravenously, so you need to be hospitalized for it. And again, it's only being given to the folks who are critically ill and are worsening and requiring lots of oxygen, for example. So these are predominantly ICU patients. It's in short supply globally, and that's another reason why it's only being used on those who are most in need. And, hopefully we will, see more medicines like this that are effective coming out, because right now with the newest variant, some of our monoclonals that we had used in the past they're not as effective. And so we definitely need for new monoclonals or any therapy to come along that's going to be helpful.
Is Paxlovid more successful in those who received a bivalent vaccine?
It does appear to provide some additional protection. There was a study, a VA study done in the VA health system who tested people who tested positive, 56,000 individuals. About 9,000 of them were given Paxlovid, and they saw a little bit more significant reduction in long COVID and reduction in post-acute deaths and hospitalization. So it does appear, but again, this was one study done, significant amount of people, but this goes similar to everything with long COVID in general, that there are still studies ongoing to understand.
Status of an inhalant delivery mechanism.
So as far as I know, and I will defer to Dr. Brown if she has something more recent, as far as I know, those studies continue to be going on and they're pretty successful, but I've not heard that they're commercially available just yet. Dr. Brown, do you know anything more than that?
I don't. Just as what you said, around the world, they're looking at different options, but nothing been approved.
Yeah, from what I know, the most recent studies that I've seen, they all look very encouraging, but they just haven't gotten across the threshold of becoming commercially available yet.
Okay. Any new preventive medicine pending?
So the FDA is looking at approval, but it's going to take some time. There is a medication in Japan, Zocava, I think is how you pronounce it, or Exocava, that has been approved again in Japan, and the FDA is looking at that, but that's going to take a little bit of time.
A little bit of time. Okay, those are all the questions that we have for this 98th session of COVID Talk with Local Health Authorities. Okay, folks, we have, 2 more to go? Thank you for joining us with COVID-19 Talk with Local Health Authorities. Joining us, representing Harris County, is Dr. Erica Brown. Representing the City of Houston, Dr. David Purse. Special thanks to past President, Rotary Club of Houston, Kathy Finninger, our producers, David Castillo, Priscilla Key. I'm Stephen Williams, the Director of the Houston Health Department.